points. It has some subtitles like review of literature has 10 points. The subject and content has 10 points. Quality of your presentation has 5 points, and your maintenance and the strictness about your time management is 5 points. And for the discussion, another 10 points. And message and practical applications and implications take home message about your paper will have 10 points. These are all the subdivisions of the total points which are given. So your time for presentation is 2 minutes, sorry 6 minutes, sorry, and the discussion is 2 minutes. Yeah. So I request all you to note these things and stick to your time on your presentation. And we will remind you at 5 minutes, and another second bell at 6 minutes. One bell is 5 minutes, two bells is 6 minutes. Then your time is over, right? So now I request Dr. Raghuram sir to call upon the PG gold medal presenters.
Good morning. First I will call upon the PG speaker, Dr. Nazim Kazan. Please come over and present your paper.
Good morning everyone. My name is Nazim Kazami, postgraduate from Osmania. So my study is a comparative study of functional outcome of OFAS fracture treated by various surgical modalities at a tertiary care center. The volume fractures constitute 1/3 of all fractures on taking account of the femur alone. But most fractures involve around the shaft of femur. Distal femur fractures constitute 3 to 6% of all femur fractures and 1% of all orthopedic trauma. Distal femur fractures can be either supracondylar or condylar type. Condylar type involves in two planes, sagittal and coronal planes. OFAS fracture is a coronal oriented fracture of the distal femur with fracture line extending through the medial condyle or lateral condyle or bicondylar. It accounts for 8.7% to 13% of distal femoral fracture. This fracture type was first described by Bush in 1869. In 1888, OFA described coronal fracture of the femoral condyle but did not indicate the source of the previous reference. Coronal plane femoral fractures are more common in young adults as a result of high velocity trauma. But some cases also have been reported in pediatric and geriatric group as a result of low velocity trauma because of osteoporosis. Both conservative and surgical management can be done depending on the degree of displacement and the type of fracture. Non-displaced OFAS fractures can be treated conservatively with a cylindrical plaster cast immobilization with knee in 10 degrees of flexion to avoid a gastrocnemius pull. For displaced OFA fracture, cannulated cancellous screws fixation or plate fixation can be done. Screw fixation can be done either by open approach or percutaneous approach or arthroscopically. The challenges in fixing the femoral condyle are also huge since the fracture extends intra-articularly. It is necessary to restore the anatomical joint congruity. The aim of the study is to evaluate the functional outcome of OFAS fracture treated operatively by various modalities and to analyze the duration of union of OFA fracture managed by various surgical modalities and assess outcome by using Knee Society score. The classification used was Letanier classification. There are 3 types. Type 1, vertical type of fracture that runs parallel to the posterior cortex of the femur and located adjacent to the attachment of ACL and LCL. Type 2, fracture horizontal to the base of the posterior condyle and lies posterior to the attachment of LCL. Type 3 is oblique type of fracture. The fracture line is located anterior to the joint capsule ACL, LCL. Type 1 and type 3 have the best prognosis. Type 1 is the most common type. So management. So it can be managed by conservative and surgical. So indications for conservative management are type 1 undisplaced fractures, patients with multiple comorbidities, bedridden patients and elderly patients. The contraindications are type 2 and type 3 displaced fractures, cast loosening, severely comminuted fractures, fractures going in non-union, and fractures associated with multi-ligament injuries. So various methods of surgical management are open reduction and lax screw fixation, open reduction with headless screw fixation, open reduction and fixation with locking compression plate, cancellous screws combined with anti-glide plate, and arthroscopic assisted fixation. So steps of the lax, this is the most common procedure which is done, the lax screw technique. The steps are: drill hole for the cancellous screw, drill the neocortex of cancellous bone crossing the fracture site, do not perforate the far cortex, determine the screw length, use a depth gauge to determine screw length, tap with cancellous bone tap and should not tap the far cortex, countersink the neocortex. It is used to bury the screw head in the neocortex in case of screw insertion in articular surface. Insert the screw, the proper measured length is inserted and tightened. While tightening, the screw case should be taken not to crack the neocortex. The patient positioning is a supine position with knee flexed in 30 degrees. The patient should be placed in supine on a radiolucent table, placing the knee in 30 degree flexion. The knee should be supported by rolled sheets. The external rotation of the limb should be prevented by placing a cushion below the buttock. So various approaches, minimal invasive osteosynthesis approach from lateral or anterolateral, medial parapatellar approach, lateral parapatellar approach, medial approach, modified Schwarzböckler, and we are doing a plating posterior approach also. So reduction. After exposing the femoral condyle, a large pointed reduction clamp can be used to hold the fracture fragment, and anatomy of the joint congruity must be checked before fixation. A joystick technique can be helpful in difficult cases where a shank pin is inserted into the HOFA fragment and rotation can be controlled through this pin, after which reduction clamp can be applied. So guide wire placement. The guide wire are placed in an antero-posterior fashion, and axis of the guide wire must be exactly perpendicular to the fracture site. This should be done under image intensifier control. By inserting guide wire, the opposite condylar surface should not be breached. So my study included 20 cases, and the study period was 2 years. Inclusion criteria was patients with HOFA fracture of the medial or the lateral femoral condyle, patients in the age group of 18 to 60 years, patients willing to give informed consent. Exclusion criteria was patient below 18 years, patients who are medically unfit for surgeries, pathological fractures other than osteoporosis, patients having associated head injury and neurovascular injury. Investigations which were done were X-ray knee joint, antero-posterior view, X-ray knee joint, lateral view, X-ray knee joint, oblique test view, CT scan and MRI. So clinical evaluation was made on the basis of Knee Society score, which includes pain while walking, pain while climbing stairs, range of motion, stability, medial, lateral and antero-posterior. And deductions were extensor lag, tendon contracture, malalignment, pain at rest. So the maximum score is 100, and the score is 80 to 100. It is considered excellent. 70 to 79 good, 60 to 69 fair, less than 16 poor. The mean
Dr. Nazim, your time is up. So it's open for discussion. Any questions? So your topic is isolated
yes, sir, isolated purpose.
fractures. So what percentage of distal femur fractures have isolated corpus?
So 8 to 13%. Mostly it is associated with supracondylar or when CC screw fixation was done alone. Adding anti-glide plate gave a stable fixation, and we were able to start earlier range of movement early on.
So you have those cases also?
Yes, sir. I have case examples.
So is that the conclusion? Can you just tell the conclusion?
Sir. So my case study included 20 patients, sir, and the 4 modalities were used. CC screw fixation from anterior to posterior direction, CC screws from posterior to anterior, compression plate alone, and a screw combined with plate, sir. Screw with plate gave early union and early range of movement. Come afterwards, followed by C-screw fixation from posterior to anterior direction, followed by C-screw fixation from anterior posterior, so followed by the plates.
Sir, any more questions?
Can you give them my posterior to anterior direction?
Yes, sir.
So, which approach do you do? So, putting a screw or what are screws posterior to anterior is not easy.
Yes, sir. Posterior lateral approach was done, sir.
Okay, even then also.
Sir.
So, because gastrocnemius, lateral gastrocnemius comes there. And to put a posterior, that posterior to anterior is just vertical, perpendicular to the fracture is not that simple. And how many cases did you do arthrotomy? In your 20 series,
Sure.
25 series, how many did you do arthrotomy?
So, cases which are operated by medial parapatellar and lateral parapatellar, every case we have done, sir.
And how many times you have done from posterior to anterior, like I said, the posterior approach? Because you cannot actually see the direction, right, in that case.
It's a difficult approach, sir, but gave early union, sir, compared to anterior.
What I mean to say, how many cases?
5 cases, sir.
Sir, any more questions?
How many you treated conservative method? Conservative method.
So my study did not include conservative.
That's why I asked.
But are there any indications for conservative?
Yes, sir. Type 1 undisplaced Letenauer can be treated.
No further questions? We'll go ahead with next speaker.
Thank you, sir.
Thank you. Keep to your time so that you can complete your whole presentation.
Yes. Good morning, everyone. The title of my study is correlation between preoperative D-dimer level, coagulation profile, and patients with acute fractures. Can we have the next slide? So D-dimer is a fibrin degradation product, and basically a fracture, it triggers endogenous and intrinsic and extrinsic ways of pathways of coagulation. So D-dimer is often used to screen for deep vein thrombosis, and even fractures are known to are a known cause for risk factor for deep vein thrombosis. And this study evaluates the level of D-dimers in patients with acute fractures. So apart from, it has already been reported that cancer, sepsis, surgery, and critical illness is a known, are conditions where D-dimers are said to be raised. So apart from this, we've also evaluated coagulation profile in patients because we are D-dimer and DVT is known to cause deranged coagulation profile. So we will even evaluated the coagulation profile in this study. So the main objective was to study the preoperative D-dimer level at various fracture sites and correlate it with severity of trauma, and also to correlate it with coagulation parameters like PTINR and APTT. Additionally, we also correlated inflammatory markers like serum ferritin, ESR, and ESR, LDH, serum ferritin with the number of fractures. So this was a retrospective study, and the sample size was 245. Patients admitted between September 2020 and March 2022 with acute fractures were included. And we collected PTINR, APDT, D-dimer, ferritin, LDH, ESR, and the other demographic details. Patients who were on routine anticoagulants were not included in the study. Apart from this, patients with known deranged coagulation parameters were also not included in the study. The D-dimer assay was done using nephelometry method, and PT and APDT was measured using hemostatic autoanalyzers. we used SPS version 23 for analysis, and we used the Spearman correlation test to find the correlation between various parameters. A brief note on the severity of trauma. We cannot apply ISS, the injury severity score for this case, because we didn't have patients with severe head injuries. We didn't have typical cases of polytrauma. So what we did is every long bone fracture was counted as 1, and if there's a bilateral femur shaft fracture, we counted as 2 fractures. Similarly, malleolar fractures, bimalleolar, trimalleolar, they were counted as 1 fracture. And multiple rib fractures were also counted as 1 fracture. And in the wrist, like radial styloid, ulnar styloid, these were also counted as 1 fracture. And phalangeal fractures, metacarpal fractures in the hand, it was counted as 1 unit for the purpose of correlation. So coming to the results, the mean age of the patients was 47.23 years, and the mean D-dimer value was 3,184. The normal range is usually said to be below 500, but the mean value for patients with fractures, with either a single fracture or polytrauma, the mean value is 3,184. But PTINR and APTT, the mean value was in the normal range. Additionally, LDH and ESR, LDH was in the very close to the upper limit, but ESR is elevated, and ferritin also is in the normal range. So coming to the rise in D-dimer levels according to the fracture site, the highest rise was noted for for femur fractures, and coming to the various sites, we had highest rise was noted in subtrochanteric fractures, which is 5,620 micrograms per liter, then intertrochanteric, and then shaft. And coming to the other lower limb injuries, the both bone leg fractures, we had highest rise, that is 3,318. And you can see we had 1 case each of bilateral femur shaft and bilateral tibia shaft fractures. So in both the cases, 7,000 and 8,000. So basically, this reinforces the fact that more the number of fractures, higher the rise in D-dimer levels. We also have fractures for upper limbs. So humerus, 3,850, humerus shaft, 2,043. For the most common injury, that is both bone forearm, we have 912. Isolated, we had 2 cases each of radius, distal radius and radius shaft, where the raise was in the range of 800 to 1100 units. And around the elbow, we had 1 case each, so 160 for the olecranon and 939 for the radial head. So this is the correlation analysis. We had significant association between D-dimer, LDH, D-dimer and number of fractures, ESR, and number of fractures and LDH. So the conclusion is that the higher the number of fractures, higher the rise in D-dimer. The PTINR and APTT were in the normal range, and upper limb had considerably lesser amount of rise in D-dimer. And similar findings have been reported in other studies as well. Liu et al. Said, they reported that PT and APTT could be abnormal, but the change is limited. Okamura et al. Reported D-dimer levels only in hip fractures, whereas this study included fractures from basically all types of fractures. And Zhang et al. They correlated with the severity of injury, that is the number of fractures. And we had similar findings when compared to Zhang et al. And Liu et al. Additionally, we also had significant association between number of fractures and LDH and number of fractures and ESR. So the take-home point is, higher the number of fractures, higher the rise in D-dimer, and D-dimer is not a very reliable indicator for screening for DVT in patients with fractures. You have to rely on other parameters like CTPA and Doppler. Thank you. We didn't include that, sir.
But what percentage of you
Yes, sir.
studied
Yes, sir.
lower limb fractures,
Yes, sir.
everything, right? What percentage of them had fat embolism?
Actually, in the observed patients, only one patient had known DVT, and 2 patients had fat embolism like signs, like sudden drop in saturations and fever, altered sensorium. They were seen in 2 patients with the bilateral femur shaft cases, and the other case was an IT fracture.
A very warm good morning to everyone, respected chairpersons and august audience. Fracture neck femur between 60 to 75 years, treated with dynamic hip screw along with autologous hemicircumferential fibular graft. Analysis of the results. We come to this world under the brim of pelvis and go out through the neck of the femur. This is one of the famous quotations from Watson Jones textbook of fractures, which explains how difficult it is to treat neck of femur fractures. Coming to the treatment options, we usually prefer osteosynthesis before the age of 60 and arthroplasty after the age of 75. But between the age group of 60 to 75, joint preservation with internal fixation can be considered, but it has its own difficulties. Like 1. Achieving anatomical reduction. 2. Stabilization of the achieved reduction. 3. As these fractures are difficult to unite, we need biological augmentation and we need to prevent late complications like avascular necrosis. So the main objective here is to address all these issues and get good results. We have reduced the fractures on a standard fracture table following the basic principles and preferred a valgoid reduction of 0 to 5 degrees. Coming to the stabilization part, initially we have inserted a thick long K wire proximally and parallel to the standard guide pin to prevent rotation. We have reduced the tip effect distance between 5 to 10 mm to get a good purchase within the femoral head. The lateral end of the lag screw was placed 10 to 12 mm medial to the lateral cortex entry point to get good compression effect. We have used a 2-hole long barrel DHS for fixation. We avoided derotation screw in all our cases to reduce the amount of metal work within the femoral head. This is a journal article that shows that usage of derotation screw does not aid in union. Coming to the biological augmentation, we have used and harvested an autologous ipsilateral hemicircumferential fibular graft, and we have taken only the lateral half of the fibula, maintaining the integrity of the host fibula. Coming to the usage, it increases the stability of the fracture fixation, increases the union, decreases the collapse, and decreases the chance of AVN. Coming to the AVN prevention, we have advised early and mandatory removal of DHS after achieving union at the end of 18 months to all our patients, as it simulates the core decompression effect, restores the normal anatomy, and decreases the chance of AVN. Ours was a prospective clinical study which was conducted between 2014 to 20 in total of 19 patients with a mean age of 66 years. All the fractures was displaced. The mean hospital stay was 6 days. The duration of surgery for DHS plating was 70 minutes and for fibula grafting was 40 minutes. We have included the patients with Gardner type 3 and type 4 fractures, subcapital and transcervical types. We have excluded patients with pathological fractures, non-unions, delayed presentation, fractures with hip dislocation, osteoporosis, and pre-existing osteoarthritis. In post-operative phase, from day 1 we have advised in-bed mobilization and exercises. From the 3rd week we advised touchdown weight bearing with support, and from 4th and 5th week we have advised progressive partial to full weight bearing depending upon the union status. Coming to our results, out of total 19 patients, 15 achieved union, 2 failed to unite, 2 went into AVN, and the neck shortening was observed between 5 to 8 mm. This is a case report of 74-year-old male who showed good clinical results after fixation. This is another case report of a 63-year-old female who showed good functional outcome after fixation. In this image, you can see how beautifully and excellently she is able to sit down and squat and cross-leg. The selection of our cases was based on the bone stock of the femoral head. Smith & Nephew conquest system, Osgood-Targan system are some of the novel methods, but we did not have experience in using them. CC screws were not preferred as they offer a less stable fixation. 2-hole DHS plate was used compared to a 4-hole, and literature is in favor of it. The tip effect distance was reduced to 5 to 10 mm to get a good purchase and stable fixation. Hemifibula acts as a biomechanical augmentation, and that is the main advantage. We have achieved inherent stability by compression effect that improves the union. Considering the Indian scenario and the socio-economic status of the patients, joint preservation with internal fixation has to be considered in some patients. We need to have an optimization and a balance between compression and collapse. Compression effect is needed in these fractures as the union occurs between thick cortical bone and cancellous bone. On the other hand, if there is extensive collapse, there is extensive neck shortening, resulting in alteration of biomechanics of the hip. We have our own limitations like a small sample size, a short-term follow-up, and we did not conduct any in vitro studies for the tensile and shear forces acting upon the DHS lag screw. This is the data sheet. These are the references. And to conclude, I would like to say that joint preservation can be considered in some of the patients with fracture neck femurs between the age group of 60 to 75 years. Optimized fixation with DHS screw along with autologous hemicircumferential fibular graft gives good functional results and lesser complication rates. Thank you.
Good morning to all. My topic is prospective analysis of outcome in the management of post-traumatic bone defect in tibia by mascara. Coming to the introduction. Bone defects result from compound fractures of long bone, mostly due to high velocity road traffic accidents, and the incidence of open fractures is about 4.5 million per year in India. In early 20th century, the patients had to undergo an amputation as a life-saving measure due to severe contamination of wound and due to severe bone gap. Management of bone defect is very challenging. Small size defect of less than 2 cm can be easily managed by non-vascularized cancellous bone graft. Before the advent of bone transport procedures for a large bone defect, shortening of limb was the result. For a segment of fibula was used to manage the defect in the tibia. Bone transport is a widely accepted technique for the management of very large bone defect. And Ilizarov technique is one commonly used technique, and it requires specialized training and steep learning curve. Mascara technique assures a simple, alternative and viable management of large bone defect up to 25 cm, as it can be done in health center without much facilities and expertise. In this technique, a cement spacer is placed in a post-traumatic bone defect. Its presence helps in preventing fibrous ingrowth into the bone defect and induces formation of biomembrane around it. Bone graft placed within this chamber of induced membrane incorporates into functioning bone. The membrane prevents cancellous bone resorption and promotes cancellous bone corticalization. In our study, it was intended to review the clinical, radiological and functional outcome of bone defects in tibia managed by mascara technique. The stages of mascara technique, the first stage include radical debridement of the defect and skeletal stabilization and insertion of an antibiotic-coated polymethyl methacrylate cement spacer into the bony defect. The spacer has a biological role by inducing a foreign body reaction surrounding the spacer, which will support subsequent bone grafting procedure. The membrane prevents the resorption of contained cancellous bone graft. The induced membrane has an appearance similar to fascia and is highly vascularized and has got two parts. Smooth inner part, which is like synovium, and the outer part consists of fibroblast, collagen and myofibroblasts. The biomembrane contains abundant number of osteoprogenitor cells and also secretes growth factors. The second stage after 4 to 8 weeks involves removal of cement spacer while preserving the biofilm. An interval of 4 to 6 weeks is required for development and maturation of a biologically active membrane. Aho and his colleagues studied that a 1-month-old membrane has got high osteogenic factors as compared to a 2-month-old membrane. The induced membrane is incised carefully and the cement spacer is taken off with an osteotope. The gap is filled with the fresh cancellous autograft and the membrane is sutured with the absorbable suture so that the grafts are contained inside the defect. The biomembrane wrapped around the cancellous bone has a protective effect against the bone resorption. The cancellous bone is capable of forming bone even without stress to the bone. Classification of bone defects: significant bone loss occur only in a small proportion of all fractures. The majority of these fractures are vestibular grade 3B injuries. Cargill's classification, type 1 is less than 2 cm defect and type 2 is 2 to 5 cm defect and type 3 is 5 to 10 cm defect and type 4 is more than 10 cm defect. In our study, we have included type 2 bone defects. Management, preliminary management includes soft tissue care. We have to give wound wash and with 9 liters of saline, and thorough debridement has to be done, and we have to fix the bone fragments with an external fixator. In patients with skin loss over the fracture site exposing bone flap, flap cover is planned along with stage 1 mascara technique. Wounds with good muscle bed and not exposing the bone are covered with split skin wrapping. Antibiotic cement spacer application. Higher viscosity cement elude antibiotic more effectively than low viscosity cement. The cement spacer provides structural support. The amount of antibiotic to be used is controversial. Our preference is 4 grams of vancomycin powder per 40 grams of cement package. The antibiotic powder is mixed with the cement powder. The monomer is added to the powder and then mixed with the spoon. When the cement becomes doughy, it is then rolled by hands to create a rectangular or a square shape, approximately same as length of bone detector. Stage 2 bone grafting will keep the graft. These are the methods and materials. This is the prospective studies conducted in Osmania General Hospital, and sample size of the study was 20. These are the inclusion and exclusion criteria. Preoperative evaluation patient, we have done the preoperative workups, routine blood investigations and X-ray, and drain is removed on postoperative day 2, and the suture removal done on postoperative day 12, and stage 2 procedure is done after control of infection by serial monitoring of EHR CRP. And follow-up is done, and during follow-up we have checked for maintenance of normal mobility, intact infection, radiological assessment, and assessment of implant. Clinical outcome is measured using ASMI scoring system. These are the scoring system used for bone union outcome and functional union outcome. This is the mean duration between the trauma and the first stage surgery was 30 days. Average follow-up period is 12 months. All affected legs were skeletally stabilized with external fixator. The mean interval between the first and second stage was 43.8 days. We confirm the union clinically by absence of pain and abnormal mobility at the fracture site. In all patients, successive radiograph showed improved bone graft integration and maturation. These are the results.
What is your conclusion?
Masculine technique is an alternative for bone detector because now the Elizaro technique and other techniques are good, but that is
postgraduate Apollo Medical College, and my topic for presentation is treatment management of distal tibia osteosarcoma. So coming to the introduction, distal tibia is quite an uncommon location for primary malignant tumors of bone. And with most of the resections include the articular surface, thereby making the reconstruction of these defects quite complex, owing to the complex bony anatomy and less soft tissue cover. Previously, people have been using below-knee amputation and also centralization of fibula, but the centralization of fibula has its own complications like long time to hypertrophy, prolonged periods of non-weight bearing, failure of the graft, and even the fixation implants. So, material and methods, we have had 4 patients with distal tibia osteosarcoma, 2 males and females, and preoperatively we have obtained the radiographs and MRIs for planning the resection margins, and 2 to 3 centimeter bony margin along with the soft tissue cover and biopsy start were planned. So, surgical technique, we have used supine position with an anterolateral incision. The anterolateral incision has helped us in harvesting the ipsilateral fibula graft and also the lateral plating with ankle arthrodesis. So, after resecting the tumor, we have sent it for extracorporeal radiation for about 20 to 25 minutes. We have packed the entire tumor in a saline-soaked mop with vancomycin and sent it for radiotherapy for about 20 to 25 minutes. In meanwhile, we have harvested the fibula graft, and then after the radiated tibial segment has come, we have stripped all the soft tissue and the marrow, and then prepared the fibula tibia so that we could telescope the fibula into the extracted tibia. So then the talar dome and the distal tibia articular cartilage was burnt for helping in ankle arthrodesis. After telescoping the fibula about 1 centimeter proximally and distally, we have fixed it with a lateral compression. So post-operatively, we have started immediate non-weight mobilization, and partial weight bearing was started about 6 months and full weight bearing at about 9 months. after we have seen radiological signs of union. And we have followed up the patients at every 3 months, and for radiological outcome, that is union at the osteotomy sites, oncological, that is to check if there's any recurrence or not, and also reconstruction to see if there's any graft failure or implant failure. Functional outcome was reported only after full weight bearing and signs of union. So coming to results, we have had 2 males and females, and the mean resection length was about 8 centimeters. And follow-up, there were no reconstruction failure, graft failure, or infections with the patients. Two of the patients had delayed wound healing, but it was managed conservatively with frequent dressings. So coming to the results, proximal junction union was seen about 28 weeks and ankle joint union about 17 weeks. Partial weight bearing was started at about 6 months and full weight bearing at about 9 months. And the mean MSTS score was about 28.25 out of 30 and American Orthopedic Foot and Ankle score of about 83 out of 100. Video. So these are the walking videos of 2 patients. The first patient has been operated in 2021, and that is showing his full weight bearing mobilization at about 1.5 year follow-up. And the second patient has been operated in February this year, and we have started toe touch weight bearing with about 4 months. So discussion, reconstruction following the resection of distal tibial tumors is always a challenge. Below knee amputations have been practiced previously, but they have a serious psychological impact on the quality of life of the patient. There are a variety of limb salvage procedures like autogenous bone grafting, where it has its own complication like delayed weight bearing and graft failure, and infection and graft lysis with allograft, and inadequate soft tissue cover leading to infection in endoprosthetic reconstruction. So the use of ipsilateral fibula has been the most common method, but to achieve fibrillization of fibula, it takes a long time to hypertrophy. So it has its own complications leading to non-union of the osteotomy site and deformity or failure of arthrodesis when minimal fixation was used. So Cabana has described the use of an allograft combined with a vascularized fibula with long length femur defects. The allograft added strength to the construct, whereas vascularized fibula helped in union across the junction. Similarly, we have used TCRT distal tibia instead of allograft, combined with a non-vascularized fibula autograft, as the resection was less than 10 centimeters. So, and the advantages of the recycled autograft were over allograft, where there is minimal risk of graft rejections and transmitted infection. So the take-home message is we have moved on from below knee amputation to centralization of fibula for reconstructing the distal tibia excision to newer methods where we use intraop radiotherapy and then help in reconstruction of the tibia.
Good morning, one and all. Today I am going to present about fingertip preservation techniques and some tips and tricks for subtotal amputation. So it is not very uncommon for us to find these fingertip injuries, and also we have to also know some techniques to prevent these sort of complications during fingertip injuries. So the aim of our study is to assess the outcome of the fingertip preservation and also to come out with some tips and tricks so that we can save the subtotal amputation. So fingertip is a very precise sensory organ that helps us to do our day-to-day activities, and any injuries to these fingertips can cause gross dysfunction. It has a very complex anatomy with different complex structures, and there are a lot of variety of types of amputation: total amputation, near total amputation, and subtotal amputation. So total amputation, you can clearly see that it's a traumatic detachment of the body part. Near total and subtotal, the judgment is ideally taken intraoperatively. So do not take we should not take a judgment whether to amputate this or to save this before going into the surgery. And Allen's classification is used for deciding the type of amputation plus total. Type 1 includes only the
pulp defect, and type 2 pulp and tuft of the bone is amputated. Type 3 up to the sterile matrix and extending into the germinal matrix along with bone loss. Type 4 is complete detachment proximally. So coming to our materials and methods, 32 fingertips were operated in 26 patients between a duration of September 2020 and January 2022. Age group was 2 years to 55 years, and 20 people were male and 6 patients were female. All the patients presented to us primarily, and we could operate them within 6 to 12 hours after injury. None of them underwent conservative management. So we had 21 cases of total amputation, 3 near total and 8 subtotal. So majority, 65% were total amputation. And again, Allen's classification, majority were type 2, that means distal tuft and sterile matrix were gone. And based on the geometry, we had more of volar oblique amputations, because the volar part is the one which is more prone for injury. So that we could correlate. And coming to the mechanism of injury, we had door crush injuries, bike chain crush injury, knife cut injuries, and mixer grinder injuries. And door crush injuries, especially children and infants putting their hands indoors. Mixer grinder injuries common in the women household, and bike chain crush injuries in young men, and slicing injuries. So coming to the management, it depends on the type of amputation. And for total amputation, we have used for dorsal oblique, we have done a VY flap. For volar oblique, we have done a cross finger flap. And for transverse, we have either done a closure or a flap. Coming to near total amputation by definition is an amputation which does not have distal viability. So because it is non-viable distal part and a very small for reconstruction, it needed nanosurgery which did not be done. So easy job is to convert it to total amputation and then do a flap or a closure. Subtotal amputation is the trickiest one. We have to save the subtotal amputation, and all the care has to be taken to save this part and its viability. We have the subsequent steps how to save it. So coming to the management, total amputations, we have operated 3 by closure and 2 by VY flap. Volar oblique, 8 cross finger flaps were done and 7 advancement flaps were done. And to all the near total amputations, we have done VY advancement flap, and subtotal amputation, we have done a primary closure. And regular dressings were done, and follow-up was done until full healing. Monthly follow-up was done, and at 6 months we took a dash score after the completion of the follow-up. We also had more follow-up, but 6 months was the time which we took for dash score management. 28 were right, 4 were left. Single digits were 20 and multiple digits there were 6 patients. So mean age was 23 years and mean follow-up was 8 months. We had no complications and the dash score was 86, so that was a wonderful and near normal score. So for classifying the results, we used Wang criteria, and according to Wang criteria we have analyzed. So Allen type 1 and type 2 had excellent results, and all our subtotal amputations had excellent results. The poor results were found in type 4 where a lot of bone is lost. And coming to some of the cases which we operated, dorsal oblique amputation, here we could restore the pulp space and also repair the nail bed. And at follow-up after 6 months, we have a good nail plate as well as a good rounded pulp. And volar oblique amputations, this was a bite chain crush injury, young men, which we have done a nail bed repair here, and also VY flap, which good results, and restoration of finger length. Again, a mixer grinder injury where we have done different flaps and restoration of the subtotal amputation of the nail bed repair, and good nail and nail plate and the flap. Donor side is also good. So we also found there was an epidemiological correlation. On monsoons we found door crush injuries, and cold lockdown we found a lot of bike chain injuries. And also to prevent these complications, we have found some tips and tricks, least invasive. So first tip is to handle the part with utmost care and avoid dressings. And the second tip, use a ringer block which avoids internal spasm. Avoid vasospasm by using warm saline, do not use peroxide. And tip 4 was use this tape which can stabilize and prevent ischemia. And do avoid K-wires. Even in gross displacement, it is fine. Plan your suture based on the vessels, because our suture itself can cause damage. And only loose suture, do not put tight suture. So to conclude, restoration of the fingertip anatomy is very much necessary, and least handling, least meddling with structures saves the fingertips. Thank you.
Good morning, everybody.
So my papers I am presenting on clinical efficacy and safety use of high-speed drill as well as ultrasonic bone scalpel in spinal stenosis condition. This is a retrospective, descriptive, comparative study. So what is the need of this study? When you see this image, the surgeon first sweats because this is a case of a 65 years old man with complaining of neck pain, axial movements and all the signs and symptoms of myelopathy. And these are really difficult surgeries. And there is high chance of neurological deterioration post-operatively. The patient comes walking to you and the post-operative patient may go into grade 1 and later they will have full complete neurological deficit, though they may recover in future. The patient perspective, once we explain the complications, they say, doctor, is the surgery safe? Are you capable of doing this surgery? And actually, what is safety? Safety is it assurance of neurological deterioration or is it a guarantee of an excellent outcome after surgery? Not at all. Safety is getting the best possible outcome with minimum collateral damage while doing surgery, using the best of technology with us at hand. And the safety in this kind of surgeries is to reduce the operative time during surgery and at the same time reduce the intraoperative blood volume loss and reduce the rate of complications like neural injury, spinal cord injury and neural leakages. And there are, I just want to skip this. These are two types of equipment which are available, belongs to Medtronic and Masonic. We have experience of using both these instruments since a long time. And the aim of the study is to evaluate the efficacy and safety use of ultrasonic bone scalpel for spinal stenosis in patients who has underwent surgery in Reddy Hospital. And the objective is to study the safety, to evaluate the surgical technique safety and precautions of using ultrasonic bone scalpel. This is to improve the clinical efficacy and avoiding the complications of ultrasonic bone scalpel when we are using it and handling it properly. And all the cases, the pathologies included degenerative conditions like herniated disc, cervical OPLL and dorsal OPLL. And the study is conducted in our hospital over a period of 3 years with a sample of 24 patients. And both the patients are divided into the inclusion criteria. Is patients with symptomatic spinal canal stenosis by radiologically and those who are medically fit only has taken and the age is 45 to 80 years of age and thoracic and cervical decompression was compared with the USSD. The inclusion criteria is as usual those who are not diagnosed and patients who are not fit for surgery and out of the range of the age group which we are studying. The 24 patients are divided into two groups, Group A 12 and Group B 12 and the A is treated with HSD, high-speed drill, and the B is treated with ultrasonic bone scalpel. We have evaluated three parameters, mainly the time of laminectomy, intraoperative blood volume loss, presence or absence of cerebrospinal fluid leakage and associated complications. All underwent posterior decompression, cervical and lumbar. Cervical and thoracic. And this is the data. And we have evaluated preoperatively and postoperatively the Frankel grading, neurological deterioration, and evaluated those two initial parameters like time of laminectomy and blood volume loss. Most of the patient comes to us with grade C neurological deficit because they start finding difficulty in walking when they are in grade C. And the results includes, this is how the data according to number of levels we have operated. Totally we have operated 28 levels and 20 levels in thoracic and 28 levels in cervical region. And in Group B, there are 24 total levels and 20 levels respectively in both cervical and thoracic regions. And we have evaluated three parameters, that is most important is single level laminectomy. This is a single time of single level laminectomy. In Group A is 7.2 minutes, in Group B is 4 minutes, it's significantly less. And in case of intraoperative blood volume loss, 100 ml in Group A and 84 ml in Group B. And CSF leak and associated complications, it is 3 in the frequency is 3 in Group A and 2 in Group B. The postoperative neurological function, most of the patients are improved to normal grade E, but there are few patients they were deteriorated in Group A. One is the Narurotis, C5 Narurotis paralyzed in Group A. That is a common after cervical laminectomy because of boosting effect of the spinal cord. When laminectomy done, the cord falls back and there is a stitch and the shortest root, that is a C5. And one patient deteriorated from, sorry, can you go back? Please can you go back? Oh, yeah. Sorry. One patient deteriorated in the spinal cord, that is grade C to grade B. Whereas in group B, there are no nerve root injuries. The spinal cord is only one patient deteriorated. And from that too is recovered after 8 months of treatment. The CF leakage is cervical, there are only 2 cases, and in dorsal it is 3 cases. And we have evaluated the T-value, standard deviation and P-values. It is significant in single level laminectomy and single level laminectomy with intraoperative bleeding volume loss. Comparatively, group B patients will have less time of laminectomy and less bleeding during using this ultrasonic bone scalpel. And these are the studies we have conducted. There are only 2 to 3 studies in India so far compared these two equipments in doing cervical and dorsal laminectomy. In fact, in all spinal surgeries, either anterior or posterior. And our results are really comparable to other international and national studies. The discussion includes that compared to HS, the USBS has statistically significant clinical efficacy, shortened the surgical time and reduced intraoperative blood loss, and neurological injury prevention by USSB is better than HS owing to its unique character of protecting the soft tissues and dura. Last few minutes. So this is the discussion. See, I just want to show you how it takes the cuts. The video is not playing. Can you please help me out? These 2 cases, one is cervical laminectomy, the other case is the dorsal laminectomy, where if you see the cut through the USSB, it cuts like a blade and protects the underlying dural structures and nerve roots as well as the epidural veins, so that the bleeding time is, the operative time is less, so that the bleeding is also very less, because it cuts only the bone but not the soft tissue. That I want to show you how precisely it will cut. This is the way how precisely it will cut without damaging the underlying soft tissues. And if you see the drill, this side is the drill which does not damage the soft tissues, whereas that ultrasonic high-speed drill which rotates and takes the soft tissues around it, and the chance of neural damage and dural damage are very high in this kind of things. So, conclusion, the USB ultrasonic bone scalpel is very effective in posterior decompression for spinal stenosis, significantly reduces the laminectomy time, intraoperative blood volume loss, and perhaps causes a less damage to the spinal cord, nerve root and dura mater and subsequent epidural vessels. Though it is very, very safe but frequent, this requires very high surgical skills and clinical experience to operate this. Thank you so much.
Paper is open for discussion.
It cost me 60 lakhs rupees. Basically, it is not viable, but out of passion I have taken because I want to improve my surgical skill day by day. So that is the reason I have purchased. But it has got a multi-purpose applications. It can be used for plastic surgery, dental surgery, and even for craniotomy for some cases. It is available, only imported or available.
Outcome of fractures of shaft humerus operated by minimally invasive anti-rapid osteosynthesis. Introduction. Humerus shaft fractures make up approximately 1 to 3% of all fractures. Typically, they are results from direct trauma, but also occur in sports where rotation forces are great. For example, baseball or arm wrestling. Fractures of the middle third, distal third of the shaft fractures put the radial nerve at risk. In a small percentage of cases, shaft humerus fractures are associated with vascular injury also. Open fractures are uncommon but can present serious injuries, particularly if it is associated with breast injuries in industrial injuries. Treatment models, non-operative treatment of diaphyseal humerus fractures can be accompanied with various techniques such as white glue bandage, sling and body bandage, abduction cast or splint, cooperation splint, Euslaber, hanging arm cast or functional cast dressing. Indication for operative reduction and fixation of diaphyseal humerus fractures we are first defined by bandage. Diaphyseal fractures in an unacceptable position after conservative treatment are open fractures, transverse fractures, comminuted fractures with error palsy and pseudoarthrosis. By 1996, the previous list was enlisted with segmental fractures, quadrilateral fractures, bilateral fractures and floating elbow polytrauma cases, neurological loss after penetrating injuries. Inability to maintain satisfactory reduction by closed means is one of the main indications for surgical treatment. Plating enables the surgeons to reduce and hold the critical articular periarticular fragments. Although plating can be technically demanding, the results are predictable. Associated shoulder and elbow stiffness is infrequent unless there is a periarticular interarticular extension of the fracture pain. Plating is also best for holding corrected malunions cases following osteotomy and remains treatment of choice of non-union of the tumor. Another options including intramedullary nailing. Recent designs include nails with smaller diameters which are more flexible or multiple locking options can compress the fracture. Humeral nails can be inserted as antegrade or retrograde in the rear or under manner. Minimally invasive approach should be considered to plate a multi-fragmentary humeral shaft fractures and are usually performed with a pair of incision. One is distal, one is proximal. Minimally invasive orthopedic transition techniques are challenging and have the benefit of reducing its soft tissue damage, but are not without their own risks. Our aim of the study is to analyze and evaluate the functional outcome of surgical management of shaft tumor fractures by minimally invasive anti-repeat osteoarthritis. Our objectives are clinical and radiological assessment of patients with comminuted diaphragmatic fractures of tumors treated by minimally invasive anti-repeat osteosynthesis, to assess the time of union of the fracture site and to assess the fracture outcome of fracture fixation in the patients by MEPS and constant Morley score. Materials and the source of data is patients attending the Department of Orthopedics in Government Medical College and Hospital Surapet from May 2021 to May 2022, who are diagnosed with shaft tumor fractures and waiting for surgery. The study design is prospective study period of 12 months. Inclusion criteria is fracture of shaft tumors and age more than 18 years, simple fractures, middle and comminuted fractures and spiral fractures. Exclusion criteria is patient who are not fit for surgery, patient below 18 years of age, compound fractures and vascular injury, associated with vascular injuries. Pre-operative assessment is X-ray of the affected arm including one joint above and one joint below, including the ipsilateral shoulder and elbow joint. Minimum two reviews are necessary. Anterior posterior lateral grafts are used to template the exchange of length of the implant. The fracture patterns were classified according to the OTA classification. That is orthopedic trauma versus classification. It comes under 1 to A. 1 means humerus, 2 is shaft humerus. A, B, C means simple fractures, wedge compression and complex fractures. Treatment models are discussed. Non-operative and operative management. Operative management is conventional plate osteosynthesis, intramedullary nailing and minimally invasive plate osteosynthesis. Operative management indications, absolute indications like open fractures, floating shoulder or elbow, vascular injury, bilateral femoral fractures, secondary radial pulse injuries. Radio indications like segmental fractures, inability to maintain the reduction and transfer fracture, obesity, fracture, non-union, neurological deficit or brachial plexus injuries. Minimally invasive plate osteosynthesis. Minimally invasive approach should be considered to plate a minimal multi-fragmentary humeral shaft fractures and are usually performed with a pair of incision, one distal, one proximal. The distal incision usually anterior, splitting the brachialis and avoiding the radial nerve as it penetrates the lateral intermuscular septum. More lateral distal incision can be used for a plate coming down in the lateral side, but great care must be taken to avoid the damaging radial nerve. In both cases, the incision must be long enough for the surgeon to sustain the radial nerve and median nerve and brachial artery are safe. Proximal incisions are either anterior or with a plate running along the anterior surface, or lateral with plate running lateral or spiraling around to lie anteriorly in this direction. Minimally invasive plate osteosynthesis techniques are challenging and have procedure. Incision is 3 cm long incision made approximately starting approximately 6 cm distal to the anterior part of the acromion process, and the dissection carried out with down to the humerus using the intermuscular interval. Distal incision is 3 cm long incision is made of on the anterior aspect of the arm in the middle of the middle line, 3 cm proximal to the flexion piece of the elbow. Exposure, the interval between the biceps brachii and brachialis identified. The biceps is retracted medially with the lateral cutaneous branch of muscular cutaneous nerve which is lies on the anterior surface of brachialis. Brachialis then split and longitudinally along its midline to reach the mediastinum of the anterior cortex distal humerus. The lateral cutaneous branch of the muscular cutaneous nerve is retracted together with the medial half of the split.
So how many cases have you studied and what is the